Which preventive screening guidelines should be followed when assessing a 65-year-old male with a history of smoking and no significant health issues? Discuss the relevant screenings based on current U.S. Preventive Services Task Force guidelines, including cancer screening and other relevant health conditions. Answer: for a 65-year-old male with a smoking history, the following preventive screenings are recommended by the USP's lung cancer screening. Annual screening with low-dose computed tomography (EDT) is recommended for adults aged 50-80 years who have a 20-pack year smoking history and currently smoke or have quit within the past 15 years. Colorectal cancer screening begin at age 45 and continue until age 75. Options include colonoscopy every 10 years, sigmoidoscopy every 5 years, or annual fecal occult blood testing. Abdominal aortic aneurysm ear screening, a one-time screening with ultrasonography, is recommended for men aged 65 years who have ever smoked. Blood pressure screening, at least annually as part of routine care. Diabetes screening, screening for abnormal blood glucose as part of cardiovascular risk assessment should start at age 40-70, especially in individuals who are overweight or obese. Following these guidelines helps prevent morbidity and mortality by detecting diseases early in high-risk populations. A 45-year-old woman presents to your clinic with a history of smoking 1 pack per day for the past 20 years. She expresses a desire to quit smoking. What are the most effective pharmacological and behavioral treatment options for smoking cessation, and what follow-up strategies should be implemented? Answer: for smoking cessation, the combination of pharmacotherapy and behavioral support is the most effective approach. First-line pharmacotherapy options: nicotine replacement therapy (NRT), available in patches, gum, lozenges, inhalers, and nasal spray. A long-acting patch combined with a short-acting form like gum or lozenges is often effective. Bupropion, Zyban, a non-nicotine prescription medication that reduces withdrawal symptoms and the urge to smoke. It is also effective in patients with depression. Varenicline, Chantix, a partial nicotine receptor agonist that reduces cravings and withdrawal symptoms while blocking the pleasurable effects of nicotine. Behavioral interventions: cognitive behavioral therapy (CBT), motivational interviewing, and support groups have shown high efficacy when combined with pharmacotherapy. Follow-up strategies: schedule follow-ups within 1-2 weeks of the quit date to monitor progress. Adjust medications and provide ongoing encouragement. Regular follow-ups every 4 weeks are recommended during the first 3 months, and long-term follow-up is essential to prevent relapse. MS. Garcia, a 52-year-old woman, has no family history of breast cancer, but she is concerned about her risk and asks about screening. What recommendations should you provide regarding breast cancer screening based on her age, and how would the recommendations change if she had a family history of breast cancer? Answer: for a 52-year-old woman with no family history of breast cancer, the USPSTF recommends mammography screening every 2 years for women aged 50-74 who are at average risk. If MS. Garcia had a family history of breast cancer, particularly in a first-degree relative, she may be considered at high risk. In that case, earlier screening, initiating mammography before the age of 50, could be considered based on individual risk assessment. Genetic testing: if there is a strong family history, such as BRCA mutations, genetic counseling and testing may be recommended. More frequent screening: some guidelines suggest annual mammograms for high-risk women, or additional imaging such as breast MRI may be indicated. In both scenarios, shared decision-making and discussion of risks and benefits are essential for personalized care. What are the current CDC guidelines for prescribing opioids for chronic pain in primary care, and how should a physician balance pain management with the risk of opioid misuse? Answer: the CDC guidelines emphasize a careful, patient-centered approach when prescribing opioids for chronic pain. Non-opioid therapies first. Begin with non-opioid treatments like physical therapy, NSAIDs, or antidepressants for conditions such as musculoskeletal pain. Start low and go slow. If opioids are considered, start at the lowest effective dose and short-acting formulations. Avoid increasing dosage above 90 morphine milligram equivalents (MME) per day. Short duration. Opioids should be prescribed for the shortest possible duration, typically 3-7 days for acute pain. Chronic pain treatment should include regular reassessment of benefits and harms, monitoring. Patients on long-term opioid therapy should be closely monitored with frequent follow-up visits, urine drug screening, and prescription drug monitoring program (EDPS). Risk mitigation: consider co-prescribing naloxone for overdose prevention in patients at higher risk of overdose, e.g. high opioid dosages, concurrent benzodiazepine use. Explain the role of the Mediterranean diet in the management of cardiovascular risk in a patient with hypertension and hyperlipidemia. How does this diet compare to other common dietary recommendations? Answer: the Mediterranean diet is rich in fruits, vegetables, whole grains, legumes, nuts, and healthy fats such as olive oil. It is associated with a reduced risk of cardiovascular diseases, and in patients with hypertension and hyperlipidemia, this diet can be particularly beneficial due to the following factors: high fiber intake. Soluble fiber from vegetables and whole grains helps lower LDL cholesterol levels. Healthy fats. Monounsaturated fats from olive oil and omega-3 fatty acids from fish reduce inflammation and improve lipid profiles. Low sodium intake. The Mediterranean diet emphasizes fresh foods, reducing sodium intake, which is critical for blood pressure control. In comparison to other diets like the DASH diet, dietary approaches to stop hypertension both share a focus on plant-based foods and reduce sodium, but the Mediterranean diet includes higher healthy fat intake and moderate alcohol consumption, typically red wine, which may also offer cardiovascular benefits. Mr. Anderson, a 55-year-old man with a body mass index BMI of 32, comes in for a routine checkup. What screenings should be recommended based on his risk factors and why? Answer: Mr. Anderson's elevated BMI places him at higher risk for several chronic conditions. The following screenings are recommended. Hypertension screening. Blood pressure should be checked at every visit given that obesity is a significant risk factor for hypertension. Diabetes screening. Given his age over 45 and BMI over 25, he should be screened for type 2 diabetes using fasting blood glucose or HbAC testing. Hyperlipidemia screening. A lipid profile should be done to assess for hyperlipidemia, as obesity increases the risk of dyslipidemia and cardiovascular disease. Osteoporosis screening. While typically recommended for women over 65, osteoporosis screening may be considered if Mr. Anderson has additional risk factors such as a sedentary lifestyle or smoking. Regular monitoring of these risk factors helps in early intervention and prevention of complications. Discuss how the hierarchy of evidence in evidence-based medicine (EBM) impacts clinical decision-making. Provide examples of different types of evidence and their reliability in informing family medicine practices. Answer: in evidence-based medicine (EBM), the hierarchy of evidence guides the reliability of clinical recommendations. Systematic reviews and meta-analyses. These are considered the highest level of evidence because they pool data from multiple randomized controlled trials (RETS), providing the most comprehensive information. Randomized controlled trials (RETS). RCTS are the gold standard for testing the efficacy of interventions, offering strong evidence due to their controlled, randomized nature. Cohort studies provide valuable observational data, particularly for studying long-term outcomes of interventions, but are less reliable than RCTS due to potential confounding factors. Case control studies, useful for rare conditions that they are prone to recall bias, expert opinion, and case reports. The least reliable but can provide insight in cases where high-quality evidence is lacking. Family physicians should prioritize systematic reviews and RCTS in their decision-making process, though they must also consider patient preferences and clinical context. What are the current recommended guidelines for managing diabetes in adults, including monitoring, pharmacotherapy, and lifestyle interventions? How should these guidelines be adapted for older adults with diabetes? Answer: current guidelines for managing diabetes in adults include monitoring. HbAC. The goal is typically an HbAC of 7% for most adults, with individualized targets based on patient characteristics, such as age and comorbidities. Self-monitoring of blood glucose, recommended for patients on insulin or those whose treatment requires frequent adjustments. Pharmacotherapy. Metformin, the first-line medication for type 2 diabetes. GLP-1 receptor agonists and NDLT inhibitors, recommended for patients with cardiovascular disease or chronic kidney disease. Insulin therapy may be necessary for patients with poor glycemic control despite oral medications or for those with type 1 diabetes. Lifestyle interventions emphasize a balanced diet with a focus on whole grains, fruits, vegetables, and healthy fats. Physical activity. Encourage at least 150 minutes of moderate intensity aerobic activity weekly. Weight management. Aim for a 5% weight loss to improve glycemic control. Adaptations for older adults. Individualized goals. HbAC targets may be relaxed to avoid the risks of hypoglycemia and overtreatment in frail elderly patients. Simplified regimens Prefer medications with lower risk of hypoglycemia and less complex dosing schedules. Comprehensive geriatric assessment. Evaluate comorbidities, functional status, and social support to tailor diabetes management effectively. By personalizing diabetes management for older adults, providers can enhance patient safety and quality of life. A 60-year-old woman presents with hyperlipidemia and hypertension. She has a family history of cardiovascular disease, but is asymptomatic. What is the appropriate approach for cardiovascular risk assessment and management in this patient? Answer: for the 60-year-old woman with hyperlipidemia, hypertension, and a family history of cardiovascular disease, the following approach is recommended. Risk assessment. Use of risk calculators. Employ the ASCVD, atherosclerotic cardiovascular disease risk calculator, to estimate a 10-year risk of heart disease or stroke. This considers factors such as age, gender, race, cholesterol levels, blood pressure, diabetes status, and smoking history, lifestyle modifications, diet. Advise a healthy diet low in saturated fats and cholesterol, such as a Mediterranean or DASH diet. Physical activity. Encourage at least 150 minutes of moderate intensity exercise weekly. Weight management. Support efforts to achieve and maintain a healthy weight. Pharmacotherapy. Statin therapy. Initiate statin therapy. G. Atorvastatin if her ASCVD risk is 20%, or consider starting if her LDL cholesterol is 109 mdl or if she has diabetes. Blood pressure control. Optimize antihypertensive therapy to achieve a target blood pressure of 138 mmHg using first-line agents like ACE inhibitors or ARBs. Follow-up. Schedule regular follow-up visits to monitor her blood pressure, lipid levels, and adherence to lifestyle changes and medications. This comprehensive approach aims to reduce cardiovascular risk and enhance long-term health outcomes. Describe the recommended approach for screening and managing depression in adults in primary care settings, including screening tools and treatment options. Answer: the recommended approach for screening and managing depression in adults includes screening tools. Use validated screening tools such as the Patient Health Questionnaire NIPHQ-9 to identify depressive symptoms in adults. Screen annually or at every visit for patients with risk factors. Diagnosis. Confirm the diagnosis using DSM-5 criteria and assess the severity of depression. Management. Psychotherapy, cognitive behavioral therapy CBT, and interpersonal therapy IT are effective for mild to moderate depression. Pharmacotherapy, selective serotonin reuptake inhibitors SRSE, sertraline, escitalopram are first-line pharmacological treatments. Consider the patient's preferences, side effect profiles, and potential drug interactions. Combination therapy. For moderate to severe depression, a combination of psychotherapy and medication is often more effective. Monitoring and follow-up. Schedule follow-up visits within 4-6 weeks of starting treatment to assess response and adjust the treatment plan as needed. Encourage patients to report any side effects or concerns regarding their treatment. Referral. Refer to a mental health specialist if the patient has severe depression, suicidal ideation, or is unresponsive to initial treatment. This structured approach to depression screening and management ensures that patients receive timely and appropriate care. 55-year-old male patient presents with a blood pressure of 150/95 mmHg during a routine checkup. He is asymptomatic, has a family history of hypertension, and his body mass index (BMI) is 30. What steps should the physician take to manage this patient's hypertension, and what guidelines should be referenced? Answer: the physician should follow the 2017 ACAHA hypertension guidelines, which recommend confirming the diagnosis, measure blood pressure on 2 separate occasions, ensuring proper technique, appropriate cuff size, patient seated calmly, assessing cardiovascular risk, evaluate risk factors, including family history, obesity, smoking, and other comorbidities, diabetes, hyperlipidemia, lifestyle modifications, advise the patient to adopt lifestyle changes such as reducing sodium intake 2300 mg day, engaging in regular physical activity, at least 150 minutes of moderate intensity exercise weekly, maintaining a healthy weight through diet and exercise, limiting alcohol consumption, initiating pharmacotherapy. Given its stage 1 hypertension, systolic BP 130/139 or diastolic BP 80/89 mmHg, and high cardiovascular risk BMI family history, initiate antihypertensive therapy. Options include thiazide diuretics, ACE inhibitors, or ARBs, considering the patient's specific profile. Mr. Thompson, a 60-year-old man, arrives at the emergency department with acute chest pain radiating to his left arm. He has A history of diabetes and hypertension. What initial evaluations and management steps should be undertaken? Answer: in evaluating acute chest pain, the physician should follow the American Heart Association (AHA) guidelines. Immediate assessment. Conduct a focused history and physical examination. Evaluate the nature, onset, duration, and associated symptoms. E.g., dyspnea, nausea, risk stratification. Assess risk factors. E.g., age, diabetes, hypertension, smoking for acute coronary syndrome. CG and monitoring. Obtain a 12-lead ECG within 10 minutes of presentation to assess for ischemic changes, St segment elevation, T-wave inversions. Continuous monitoring for arrhythmias should also be initiated. Laboratory tests. Order cardiac biomarkers, e.g., troponins, to evaluate for myocardial injury. Consider a complete blood count, CBC, and metabolic panel. Immediate management. Administer aspirin, chewable 160-325 mg unless contraindicated, and consider nitroglycerin for chest pain relief if no hypotension. Oxygen therapy should be provided if the patient exhibits hypoxemia, SPO 90%. Follow these steps promptly and consider further imaging or intervention based on the findings. A 45-year-old female patient with type 2 diabetes mellitus presents for follow-up. Her HbAC is 8.5% and she has been on metformin monotherapy. Discuss the management strategies to optimize a glycemic control. Answer: to optimize glycemic control in this patient, follow the ADA standards of medical care in diabetes. Review current management. Assess the patient's adherence to metformin and lifestyle modifications. Identify barriers to effective management, e.g., diet, exercise, treatment intensification. Since her HbAC exceeds the target of 7%, consider adding a second oral hypoglycemic agent or initiating insulin therapy. Options may include GLP-1 receptor agonists for weight loss and cardiovascular benefits, ZLT inhibitors for additional cardiovascular and renal protection, DPP-4 inhibitors if cardiovascular risk is a concern, lifestyle modifications. Reinforce dietary changes, emphasizing a Mediterranean diet and the importance of regular physical activity, at least 150 minutes a week. Monitoring and follow-up. Schedule regular follow-ups every 3-6 months to monitor HbAC and adjust treatment as necessary. Discuss the importance of home blood glucose monitoring. A 38-year-old male presents with fatigue and recurrent headaches. A complete metabolic panel reveals elevated creatinine, 1.8 mgl, and blood urea nitrogen, BUN, 25 mdDL. What does this indicate, and what further diagnostic steps should be taken? Answer: the elevated creatinine and BUN suggest the possibility of acute or chronic kidney impairment. According to the National Kidney Foundation's KDOQI guidelines, the following steps should be taken. Clinical correlation. Evaluate for potential causes such as dehydration, acute glomerulonephritis, or obstructive uropathy. Assess the patient's history for risk factors, e.g., diabetes, hypertension, medications. Urinalysis. Order a urinalysis to check for protein, blood, or other abnormalities that could suggest glomerular disease. Renal ultrasound. Consider imaging ultrasound to evaluate kidney size, structure, and possible obstruction. Further laboratory tests. Additional tests such as a serum electrolytes panel, kidney function tests, and possibly 24-hour urine collection may be warranted based on initial findings. Timely evaluation is essential to prevent progression to end-stage renal disease. Mrs. Jones, a 50-year-old woman, presents for a weight management consultation. She has a BMI of 35 and has tried multiple diets without success. Discuss the comprehensive management plan that addresses her obesity. Answer: a comprehensive weight management plan should include assessment of medical history, review any obesity-related comorbidities, e.g., hypertension, type 2 diabetes, behavioral interventions, implement a structured weight loss program focusing on caloric restriction, creating a deficit of 500-1000 kcal a day for safe weight loss, increased physical activity, at least 150 minutes a week of moderate intensity exercise, behavioral therapy, e.g., cognitive behavioral strategies to address emotional eating, nutritional guidance. Collaborate with a registered dietitian to create a personalized dietary plan emphasizing whole foods and reducing processed foods. Pharmacotherapy consideration. If lifestyle changes are insufficient, consider anti-obesity medications, e.g., orlistat, phentermine, topiramate, as per FDA guidelines, ensuring monitoring for side effects. Bariatric surgery evaluation. For candidates with a BMI 40 or 35 with obesity-related conditions, refer for evaluation of bariatric surgery options if other methods fail. A 70-year-old female with a history of COPD presents with worsening dyspnea and wheezing. Upon examination, she exhibits tachycardia and decreased oxygen saturation. What management strategies should the physician employ in this acute scenario? Answer: in managing acute respiratory distress in a patient with COPD, follow these steps. Immediate assessment. Perform a thorough examination, including auscultation for wheezing and accessory muscle use. Assess vital signs and oxygen saturation. Oxygen therapy. Administer supplemental oxygen to maintain SPO 90%. Taking care to avoid hypocapnia in COPD patients, consider a low-flow system like nasal cannula. Bronchodilator therapy. Administer short-acting bronchodilators e.g. albuterol via nebulizer or metered-dose inhaler (MDI) to relieve bronchospasm. Corticosteroids. Initiate systemic corticosteroids e.g. prednisone to reduce airway inflammation. Monitoring. Continuous monitoring of vital signs, oxygen saturation, and respiratory status. Consider repeat assessments of arterial blood gases (ABGs) to evaluate for respiratory acidosis or alkalosis. If the patient shows no improvement, consider advanced interventions e.g. non-invasive ventilation. A 28-year-old male presents with severe back pain following a fall. When is it appropriate to order imaging studies, and what guidelines govern this decision? Answer: imaging studies should be considered based on clinical guidelines such as the American College of Radiology (ACA) appropriateness criteria. Clinical assessment. If the patient presents with severe pain and neurological deficits e.g. numbness, weakness, immediate imaging e.g. X-ray MRI is warranted. Red flags. Investigate for red flags are indicating possible serious conditions e.g. fractures, malignancy. Red flags include age 50 or 20, history of cancer, significant trauma, unexplained weight loss. Imaging orders. X-ray. Initial imaging for suspected fractures. MRI indicated if there are neurological symptoms, concerns for disc herniation, or suspicion of malignancy. A 65-year-old woman with diabetes presents with fever, chills, and a painful, swollen leg. A physician suspects cellulitis. What diagnostic and management steps should be taken in this scenario? Answer: in suspected cellulitis, follow the Infectious Diseases Society of America (IDSA) guidelines. Clinical evaluation. Conduct a thorough examination focusing on the affected area, including signs of infection, erythema, warmth, swelling. Laboratory tests. Obtain laboratory tests including CBC to assess leukocytosis, blood cultures if systemic infection is suspected, and possibly a wound culture if there is an open lesion. Imaging studies. Consider ultrasound if abscess formation is suspected, especially if the diagnosis is uncertain. Empiric antibiotic therapy. Initiate empiric antibiotic therapy promptly, such as cefalexin for non-purulent cellulitis, coverage for Staphylococcus and Streptococcus. For patients with systemic symptoms or significant risk factors for MRSA recent hospitalization, prior MRSA infections, consider clindamycin or trimethoprim sulfamethoxazole. Follow-up. Schedule follow-up to assess the response to treatment within 4, 8, 7, 2 hours and adjust antibiotics based on culture results. A 10-year-old child with a history of asthma presents to the clinic for an annual visit. His mother reports that he has been using his rescue inhaler more than twice a week and has nighttime symptoms. Discuss the management steps and guidelines that should be followed. Answer: for asthma management, refer to the GINA Guidelines Global Initiative for Asthma. Assessment of control. Classify asthma severity based on symptom frequency, use of rescue inhalers, and nighttime awakenings. Given the reported use of the rescue inhaler more than twice weekly and nighttime symptoms, this child has poorly controlled asthma. Step up therapy. Consider stepping up therapy based on the child's age and severity. Options include increasing the dose of inhaled corticosteroids, like adding a long-acting beta agonist LABA to the ICS if further control is needed equals 12 years. Education. Reinforce the importance of avoiding triggers, proper inhaler technique and adherence to medications. Asthma action plan. Develop a written asthma action plan outlining daily management and steps to take during an asthma attack. Regular follow-up. Schedule regular follow-ups to monitor control and adjust treatment as necessary. A 50-year-old male with a history of hypertension presents with palpitations. The EKG shows a rapid, irregular rhythm with no discernible P waves. What does this suggest, and what are the management considerations? Answer: the EKG findings suggest atrial fibrillation, a fib. According to the AHOCA's guidelines, the following management steps should be taken. Assessment of rate control. Evaluate the ventricular rate of 100 bpm. Consider beta blockers or calcium channel blockers for rate control. Risk stratification. Assess stroke risk using the Chern-Vasc score to determine the need for anticoagulation. If the score is 2 or more, initiate anticoagulation therapy, e.g. warfarin or direct oral anticoagulants. Rhythm control. Consider rhythm control strategies if the patient is symptomatic or has heart failure. Options include antiarrhythmic medications, e.g. amiodarone, electrical cardioversion if a fib is of recent onset. Patient education. Inform the patient about a fib, the importance of medication adherence, and potential lifestyle modifications to reduce risks. What are the recommended guidelines for prostate cancer screening in asymptomatic men? Discuss the benefits and potential harms of screening. Answer: the U.S. Preventive Services Task Force (OSPS) recommends that clinicians inform men aged 55 to 69 years about the potential benefits and harms of prostate-specific antigen (PSA) screening for prostate cancer. The decision to screen should be an individual one, based on shared decision-making between the clinician and the patient. Benefits of screening include early detection of prostate cancer, which may lead to earlier and potentially more effective treatment. Potential reduction in mortality from prostate cancer. Harms of screening include false positive results, which can lead to unnecessary anxiety and further invasive testing. Overdiagnosis and overtreatment of cancers that may not have caused symptoms or harm during the patient's lifetime, leading to potential complications from treatment, e.g. incontinence, erectile dysfunction. A 75-year-old female presents with memory loss, confusion, and difficulty performing daily tasks. What is the appropriate approach to diagnosing her condition, and which types of dementia should be considered? Answer: the diagnosis of dementia involves a comprehensive approach that includes clinical assessment, a thorough history from the patient and caregiver including cognitive decline, functional abilities, and psychiatric symptoms, cognitive testing, standardized tests such as the Mini-Mental State Examination (MSA) or Montreal Cognitive Assessment (MoCA) to assess cognitive function, laboratory tests, routine blood tests, e.g. thyroid function tests, vitamin B levels to rule out reversible causes of cognitive impairment. Neuroimaging, MRI or CT scans can help assess for structural abnormalities in the brain. Types of dementia to consider include Alzheimer's disease, characterized by gradual memory loss and cognitive decline. Vascular dementia often occurs after a stroke and may have a stepwise progression. Lewy body dementia may present with visual hallucinations and Parkinsonian features. Frontotemporal dementia associated with personality changes and language difficulties. Discuss the evaluation process for a male patient presenting with infertility. What key factors should be considered? Answer: the evaluation of male infertility involves several key steps. History taking. Gather information about sexual history, medical and surgical history, family history, substance use, and exposure to toxins. Physical examination. Assess for signs of hormonal imbalances, such as testicular size, presence of varicocele and secondary sexual characteristics. Semen analysis. The cornerstone of male infertility evaluation. This test should assess sperm count, motility, morphology, and other parameters. The analysis should ideally be done after 7 days of abstinence. Hormonal testing. Measure testosterone, luteinizing hormone LH, and follicle-stimulating hormone FH levels to assess the hypothalamic pituitary gonadal axis. Genetic testing. Consider karyotyping or Y chromosome microdeletion analysis in patients with severe oligospermia or azoospermia. Imaging studies. Scrotal ultrasound can help identify structural abnormalities. Overall, a comprehensive approach allows for a tailored treatment strategy depending on the underlying cause of infertility. What are the key components of a brief intervention for a patient identified with hazardous alcohol use? Answer: a brief intervention for hazardous alcohol use typically consists of the following components. Screening. Use validated screening tools such as the AUDIT Alcohol Use Disorders Identification Test to assess alcohol consumption patterns. Feedback. Provide the patient with personalized feedback on their alcohol use, emphasizing the risks associated with hazardous drinking. Motivational interviewing. Employ techniques to enhance motivation and readiness to change, exploring the patient's ambivalence about their drinking. Goal setting. Collaboratively establish specific, measurable goals for reducing alcohol consumption. Follow-up. Schedule a follow-up appointment to monitor progress and provide ongoing support. The National Institute on Alcohol Abuse and Alcoholism (NIA) emphasizes the importance of these components to facilitate behavioral change in individuals with hazardous drinking behaviors. Mr. Smith, a 50-year-old man with a long history of alcohol use disorder, presents to the clinic expressing a desire to quit drinking but is unsure how to proceed. He reports frequent cravings and has tried to quit several times without success. What steps should his healthcare provider take to assist him? Answer: in managing Mr. Smith's alcohol use disorder, the healthcare provider should take the following steps. Assessment: conduct a thorough assessment of Mr. Smith's drinking patterns, medical history, and any co-occurring mental health disorders. Utilize tools like the CAGE questionnaire to evaluate the severity of his alcohol use. Discuss treatment options. Explain the various treatment modalities available, including behavioral therapies and pharmacotherapy. Develop a treatment plan. Collaboratively create a personalized treatment plan that incorporates both behavioral strategies and pharmacotherapy if appropriate. Include contingency plans for potential setbacks. Supportive resources. Refer Mr. Smith to support groups such as Alcoholics Anonymous or provide information about local resources. Follow-up care. Schedule regular follow-up appointments to monitor Mr. Smith's progress and adjust the treatment plan as necessary. Continuous support is crucial for maintaining sobriety. What strategies should be implemented in a comprehensive geriatric assessment to minimize fall risk in elderly patients? Answer: to minimize fall risk in elderly patients, a comprehensive geriatric assessment should incorporate several key strategies. Medication review. Assess all medications for potential side effects, especially those that may affect balance or cognition, e.g. sedatives, antihypertensives. The Beers criteria can guide the identification of potentially inappropriate medications for older adults. Home safety assessment. Evaluate the home environment for hazards such as loose rugs, poor lighting, or clutter that may increase fall risk. Recommend modifications such as grab bars in bathrooms and improved lighting. Balance and strength training. Refer patients to physical therapy or exercise programs focused on balance, strength, and flexibility, which can significantly reduce fall risk. Vision assessment. Ensure regular eye examinations and appropriate corrective lenses, as visual impairments can contribute to falls. Postural stability training. Teach patients techniques to improve stability, such as how to rise from a seated position safely and use assistive devices if necessary. Implementing these strategies as part of a comprehensive geriatric assessment can effectively reduce falls and improve overall mobility in older adults. Describe the approach to screening for osteoporosis in postmenopausal women. What factors influence the decision to screen? Answer: the screening for osteoporosis in postmenopausal women involves the following steps. Initial assessment. The National Osteoporosis Foundation (NOF) recommends screening all women aged 65 and older and younger women who have risk factors such as a family history of osteoporosis, a body mass index BMI 21, smoking, or history of fractures after age 50. Bone density testing. Dual energy X-ray absorptiometry (DEXA) is the standard method for measuring bone mineral density (BMD). Results are reported as T-scores comparing the patient's BMD to that of a healthy young adult. Fracture risk assessment. Utilize the FRAX tool to estimate the 10-year probability of a major osteoporotic fracture or hip fracture based on BMD and clinical risk factors. Follow-up and treatment decisions. Women with T-scores of negative 2.5 or lower are diagnosed with osteoporosis and should be counseled on lifestyle modifications, calcium and vitamin D supplementation, and pharmacotherapy options like bisphosphonates or selective estrogen receptor modulators (SERMs). What are the primary preventive measures for travelers' diarrhea, and what recommendations should be made regarding dietary choices for travelers in high-risk areas? Answer: the primary preventive measures for travelers' diarrhea include food and water safety. Drink bottled or boiled water. Avoid ice in drinks unless made from boiled water. Consume well-cooked foods that are served hot. Avoid raw or undercooked meats, seafood, and eggs. Be cautious with fruits and vegetables and choose those that can be peeled, e.g. bananas, oranges. Personal hygiene. Encourage frequent hand washing with soap and water, especially before eating and after using the restroom. Prophylactic medications. Consider prescribing prophylactic antibiotics, e.g. ciprofloxacin or azithromycin, for travelers at high risk, e.g. those with a history of severe diarrhea or traveling to areas with high rates of antibiotic-resistant organisms. Vaccination. Recommend appropriate vaccinations if available, such as the oral cholera vaccine or typhoid vaccine based on destination and risk. What are the primary types of urinary incontinence in elderly patients, and what are the recommended first-line management strategies for each? Answer: the primary types of urinary incontinence in elderly patients include stress incontinence, characterized by involuntary leakage during activities that increase abdominal pressure, e.g. coughing, sneezing. First-line management: pelvic floor exercises, Kegel exercises, and bladder training. In some cases, surgical options, e.g. midurethral sling procedures, may be considered. Urge incontinence: Involuntary leakage accompanied by a strong urge to urinate. First-line management. Behavioral interventions such as bladder training and dietary modifications, anticholinergic medications, e.g. oxybutynin or beta-3 agonists, e.g. mirabegron, may also be prescribed. Overflow incontinence. Leakage due to an overdistended bladder, often associated with bladder outlet obstruction. First-line management. Catheterization or addressing the underlying cause, e.g. prostate enlargement. Medications such as alpha blockers may be considered for men with benign prostatic hyperplasia. Functional incontinence. Inability to reach the toilet in time due to physical or cognitive impairments. First-line management. Modifications to the environment and assistance from caregivers to facilitate timely toileting. A comprehensive evaluation is essential for tailoring management strategies to individual patients' needs. What key elements should be included in the post-travel evaluation for a patient presenting with febrile illness after returning from tropical regions? Answer: a post-travel evaluation for a patient with febrile illness should include history taking, detailed travel history including destinations visited, duration of stay, activities engaged in, and potential exposures, e.g. insect bites, animal contact, food and water consumption, symptom assessment, comprehensive review of symptoms, e.g. fever, rash, gastrointestinal symptoms, respiratory symptoms, and their onset relative to travel. Physical examination, thorough examination focusing on vital signs, signs of dehydration, rash, jaundice, or lymphadenopathy, laboratory tests, blood tests for dengue, malaria, and other tropical infections, e.g. serology for Zika, chikungunya, consider malaria, rapid diagnostic tests RET if the patient has a history of travel to endemic areas and presence with fever, preventive measures. Discuss the importance of immediate medical attention for febrile illnesses post-travel and consider the need for isolation if a contagious illness is suspected.